Hi guys, welcome. Today we're going to be looking at something under the cardiovascular system. And under the cardiovascular system, today we're looking at deep venous thrombosis. So, deep venous thrombosis occurs when blood clots or a thrombus forms in one or more of the deep veins in the body. So, usually the legs. And the commonest site of the DVT is the calf and the lower limb, followed by the pelvis. So DVT also occurs in pregnancy. So clinical features, the patient is going to present usually with pain, with sudden onset, with warmth and on palpation, on local swellings, with tenderness. So on the extremities, the diameter is going to be at around 2 centimeters or greater than that. So the opposite limb from some fixed point. So in DVT related it to pregnancy and its complications as risk factors. So the left lower limb is involved in over 80 of cases, and diagnosis is made basically on the clinical presentation. So when a patient presents with DVT, what are we supposed to do? So first of all, you have to do investigations, of which you have to do a whole blood clot time. You also have to do a prothrombin time index, PTIO. Also have to do an INR, so that's an international normalized ratio. Also have to do activated partial thromboplastin time. You also have to do a Doppler ultrasound scan to rule out. You also have to do a confirmatory test, which is known as a venography. So how do you manage DVT? First of all, you have to control pain. Also have to promote venous drainage. This can be done by bed rest, elevating the involved limb. Place the foot on the bed in a slightly elevated position so as to ease the pain and fluid overload in the leg. Also have to apply a warm pack around the involved leg. Also have to encourage limited extension and flexion to the involved limb. Also have to encourage early ambulation as soon as the pain and the inflammations have begun to resolve so that you reduce the risk of the patient forming another thrombus. How do we pharmacologically manage a patient with DVT? So first of all, you have to do unfractionated heparin. We have to give 80 international units per kg by bolus intravenous injection, then 18 international units per kg per hour. So best continuous intravenous infusion for at least 2 to 5 days. So adjust dose to achieve a prothrombin time index that is 1.5 to 2.0 times the control. So we also have to lower molecular weight heparin. So we give enoxaparin sodium 1 milligram per kg 12 hourly. Also have to give subcutaneous or dalteparin 200 international units per kg per day subcutaneously. We also have to give warfarin therapy in the first day, at least 10 milligrams OD for 2 days, and subsequent doses are adjusted until the INR is 2 to 3 times the control of the 2 consecutive days. So then we get to discontinue the heparin. So the required dosage varies between 2 milligrams to 15 milligrams OD. So for calf vein thrombus, we give warfarin for 6 weeks, whereas for proximal vein thrombus, we give warfarin for 3 to 6 months. So warfarin interaction um, with aspirin, alcohol, other non-steroidal anti-inflammatory drugs such as erythromycin, metronidazole, sulfonamide, tetracyclines, omeprazole, and etc. They also enhance warfarin activity. So therefore, closely monitor the patient's vital signs. So we also have to watch out for the following complications. So recurrent thrombosis, pulmonary embolism is also another factor. So by any chance, if present, you have to start heparin 6,000 international units as a start dose, and your aim is 24,000 to 30,000 IU in the first 24 hours by continuous infusion. So the rest will be guided by the APTT, which should be 2 times the control. So where available lower molecular weight heparins, So you can also give, that is diltiazem and enoxaparin. So the dose is usually 80 milligrams per day subcut for those below 60 kgs twice a day. So for elderly, so the dosage should not exceed 40 milligrams OD. So depending on the risk of the established pulmonary embolism, further treatment may include thrombolytic therapy, thrombisectomy, also have to do inferior vena caval filters. So what prophylaxis can we do for patients with DVT? So we recommend where DVT is likely to occur, such as the hip operations where patients being done a hip replacement, or and prolonged immobilization, patient who's constantly in bed. Also have to give heparin 5,000 international units, subcutaneous VD, until the condition is treated completely. Also have to care for chronic complications, and we can give prophylaxis Clexane 40 mg per day subcutaneously. So other than that, you should always take concern of how the patient is going to present clinically so that you can be able to manage the condition prior to any complications. Thank you. I hope you've learned something.